Okay, so we're gonna do pediatric orthopedics, and this is very simple. We just have a few diseases. So first is DDH, or developmental dysplasia of the hip. So dysplasia का मतलब क्या है? कि it means कि so essentially what this disease means is it's the displacement of the femur, especially the head of the femur, and the acetabulum. So basically इनकी cooperation नहीं हो रही होती. ठीक है? So it's a spectrum of diseases in which the femoral head and the acetabulum fail to develop a normal stable relationship. So it includes three things. Either can be subluxation, which is partial displacement, or it could be complete dislocation, or acetabular dysplasia, where the cup, yani acetabulum, is too shallow for the ball or the femoral head. So the ball, yani the femoral head, slips out, especially under weight bearing. So let's look. This is a normal articulation between acetabulum and femoral head. This is subluxation because it still is this is dislocation because isko yahan pe hona chahiye tha, but it is completely out of the joint. And then this is subluxation because it still is articulating with the acetabulum, but however, not fully. So it is subluxation. And now, if you look at this, look, this is too shallow. This is deep. So जब ये shallow हो जाता है, तो उसमें properly articulate नहीं होती दोनों surfaces, which leads to DDH. So this is acetabular dysplasia, shallowness. ठीक है? So इसके क्या risk factors हैं? So this occurs in an infant, newborn child, and ये है कि अगर it's a female, firstborn. So kind of like me, firstborn female. It can also be in breech position, and why F and F, right? But why firstborn? क्योंकि जो uterus होता है वो tight होता है. Obviously, a multiparous woman, uterus will be more lax in comparison, so that can apply pressure. Breech है, and of course we have family history, which is another F. ठीक है? उसके अलावा then we have breech and oligohydramnios. So we can see that two of these conditions are associated with womb conditions, right? And then these three are associated with female firstborn and family history. So this covers this portion, but then we have associated conditions, which is torticollis, which we know is कि neck की जो abnormality होती है, metatarsus adductus, which means gets towards the midline. ठीक है? The metatarsals deviate towards the midline, and then spina bifida, in which this can be an accompanying feature. Usually, इसकी जो pathophysiology है, that is shallow acetabulum. So we saw here shallow acetabulum, and it can either be due to hypertrophy ligamentum teres. So now we need to understand that the ligamentum teres is present here, and it allows for the attachment between the acetabulum and the head of the femur, and this also brings blood supply, although the blood supply is not very significant, especially in elder individuals. But imagine this is like super thickened and it's like hypertrophied. Now what's going to happen resultantly is that the ball is not going to be able to articulate properly. So that is why a hypertrophied ligamentum teres, the head cannot properly sit in the acetabulum. Elongated capsule. So what happens is essentially there's this constant force कि ये बार बार अंदर बाहर हो रहा होता है, which means कि ये इसको उखेड़ देता है. And while it does that, it इसकी इस तरह की shape बन जाती है, and you can see that this is shallow, but it's also elongated. ठीक है? So an elongated capsule, and then the femoral head is displaced superior-laterally. So we can see here that this is the type of displacement there is. It is superior. So we see this here. Good Lord. So it's superior, it's upward, and it's laterally. So superior-laterally, right? Okay. So then let's just have a look at so we already saw the pathophysiology. So we have a shallow acetabulum. We can have hypertrophied ligamentum teres, which would then also, we also have like a elongated capsule. So this sort of goes hand in hand. And then the femoral head is displaced superior laterally in this direction for this leg, right? Which is the left leg. And then the clinical features are limited abduction of the hip, right? And of course, you could just imagine this कि जब ये इस तरह से फंसा हुआ होगा, अब ये होगा कि बॉल सॉकेट की वजह से ये इसकी रेंज ऑफ मूवमेंट ऐसे हो सकेगी. But imagine कि ये यहाँ पर है. When it tries to abduct, it's going to hit this structure right here, right? And when it hits the structure, it's not going to be able to properly abduct. So there is limited abduction, limited range of movement, asymmetrical thigh or gluteal folds. And then there's this Galeazzi sign, which is कि दोनों knees जो हैं जब आप आपस में ऐसे करोगे तो the knees are unequal, ठीक है? So there's limb shortening, right? And then there's an extra thigh crease, which is a common sign in infants. There's a limp or waddling gait in older children, and the Trendelenburg sign is positive or gait in DDH. So this is when drop of pelvis, ठीक है? Not because of weak gluteus medius in this, but because the ball and socket mechanism is not proper. So if we just recap कि हमारे पास clinical features क्या होंगे, सबसे पहले हमारे पास abduction, limited range of movement हो जाएगी, abduction नहीं हो पाएगी. उसके अलावा हमारे पास asymmetry होगी, ठीक है? asymmetry तो हमें नज़र आ गई. बट उसके अलावा हमारे पास गेट में क्या होगा, वॉडलिंग गेट होगा, लार्जर ओल्डर चिल्ड्रन में लार्जर कह रही हूँ, ट्रेंडनबर्ग हमारे पास पॉजिटिव होगा. उसके अलावा अगर हम एक और साइन की बात करें तो गलेजी साइन हमारे पास पॉजिटिव होगा, ठीक है? हमारे पास एसिमेट्री के साथ थाई क्रीज भी एक एक्स्ट्रा होगी, सो वन एक्स्ट्रा होगी, ठीक है? So these are just the clinical features that you have to remember. इसका clinical test is Ortolani and Barlow's test. So Ortolani is like basically you abduct the hip gently and a palpable clunk is heard as the dislocated head reduces into the acetabulum. So what you're going to do, this is a positive test. So what you're going to do is, so you're going to abduct this. So when you abduct it, right, you're pushing it in this direction, तो head इस direction में आएगा, right? आपने टांग को इस तरह किया है तो यहाँ पे, and it will move back into the socket. So this is Ortolani test, right? And the way that I remember this is कि Ortolani is O means कि like the ball is back, right? Ball and socket mechanism हम restore कर रहे हैं. And then Barlow's test is कि you adduct the leg and you apply posterior pressure and the head dislocates out of the acetabulum. So out means like, it's like ow, that fell off, right? So ow, out of acetabulum, okay? And then Ortolani is, it starts with an O, so we're gonna put the O back, the ball back inside. And then Galeazzi test is when the hips are flexed and the knees are bent, one knee is lower. This, okay? Okay, so then we're going to look at the investigations. So ultrasound is the gold standards for less than 6 months, is used for confirmation. लेकिन एक्सरे हम करवा सकते हैं after 6 months, right? And उसमें हमें क्या क्या features नज़र आते हैं? Shallow acetabulum, ठीक है? Displaced femoral head. Of course, ये दोनों features तो already हमें पता है कि shallow होगा, displaced होगा. Lekin Shenton's line is disrupted. Now, what does that mean? This means that this is the Shenton line. So if we start from the lesser trochanter and we move up to the intracapsular region, and then we move towards the head, and then we go through to the pubic bone, this is a continuous line called Shenton's line. But when this moves superior laterally, what's going to end up happening is that Shenton's line की disruption हो जाएगी. And the acetabular index is more than 30 degrees. So usually it should be like that. If we draw a line here and we draw a line here, then this is more than 30 degrees, right? This is the acetabular index. So your treatment here depends on the age of diagnosis. So neonate to 6 months में Pavlik harness हम use कर लेते हैं, which keeps the hip in flexion and abduction, right? So we're going to keep the वो in abduction, because what's going to happen when we abduct it is, again, like मैंने यहाँ पे range of motion दिखाई थी here, इसके जब हम इसको abduction और flexion में रखेंगे तो ये वापस reduce हो जाएगा. So we're gonna keep it in flexion and abduction. And then from 6 to 1.5, we are going to do gentle closed reduction under anesthesia and the hip spica cast, ठीक है? So if you see, this is the Pavlik harness, और ये हमारे पास flexion में, क्योंकि flexion ये है, hip को हम flex रख रहे हैं और हम abducted रखेंगे, right? तो ये इसको इसी अंदर reduce करेगा. लेकिन यहाँ पे हम क्या करेंगे? 6 months to 1.5 years में हमने क्या किया है? हमने इसको किया है gentle closed reduction anesthesia में, और फिर हमने ये hip spica cast कर दिया. So this is the hip spica cast, ठीक है. एंड देन मोर देन 1.5 में हम ओपन रिडक्शन करेंगे एंड हमें फेमोरल या पेल्विक ऑस्टियोटमी करनी पड़ेगी विच इज़ बोन कटिंग, right? So this is open reduction. And if it's more than 6 years, then it's usually unrewarding, so it's usually not of any use. And it may require pelvic osteotomy, so you might have to even cut the pelvic bones. अच्छा, फिर उसके बाद complications क्या हैं कि of course अगर femoral head displaced है acetabulum से, उसका ब्लड सप्लाई कॉम्प्रोमाइज है, तो AVN ऑफ द हेड हो जाएगा. उसके अलावा लिम लेंथ डिस्क्रेपेंसी, वो तो वैसे ही होगा. रेजिजुअल हिप डिस्प्लेजिया हो सकता है. एंड देन वी कैन ऑल्सो हैव अर्ली ऑस्टियोआर्थराइटिस, ठीक है.